Good afternoon, everyone. Really excited to have you all join us for our 12th quarterly expert roundtable titled Stroke of the Pen, Risk and Reward, Shaping Regulation to Meet the Promise of Digital Health. So before we welcome our guests to the stage, I'd like to quickly set up the conversation. We often talk about quote unquote stroke of the pen risk. And that's the idea that as new legislative changes come, products or companies can be rendered obsolete, can be forced into a pivot, may have to adjust the way that they deliver care. Large health systems, health plans, life science organizations adjust as well and often have entire departments dedicated to it. I was a part of this in a way. I spent about 5 years of my career working with community hospitals, navigating the ups and downs of the implementation of the Affordable Care Act up until 2014. And in this timeline that you're looking at, it's obviously not comprehensive, but highlights a number of important regulatory milestones over the last 15 years. Aside from these pieces of legislation taking a lot of time, what's often the case is that these changes make for opportunity for entrepreneurs as well. So we call this stroke of the pen reward. So value-based care reimbursement models, patient data access rights issues, waivers for virtual care have all created opportunities for new solutions that didn't previously exist. And there are changes on the horizon, as there always are. The recently introduced No Upcode Act, the expiration of the public health emergency, proposed changes to home health reimbursement and drug pricing are all hot topics that we're dealing with right now. So these can be both risks and rewards for entrepreneurs and big company operators alike. So the question of this webinar and today is, how should we be reacting to all these changes? How can we make best use of them? And is reaction our only option, or can we play a more active role in shaping policy of the future? So many of our guests today have lived both lives, both as policy shapers in government, have also been in the private sector. So we'll hear plenty of examples in the next hour from both sides of that equation. But what's important here is that we're all active participants in the conversation. It's up to us to engage in the debate around policy, use our experience with patients, users, members to inform our leaders in government. So we'll be talking about that over the next hour. And we've structured it into 3 pieces. So we'll have 3 panels. The first will be the quote unquote state of play. So what are key regulations and issues impacting us today? Then we'll move into a startup case study panel. And then lastly, we'll set the groundwork for what's coming in the future and how to think about that and engage in it. So joining us in these conversations, I'm excited to be joined by some real healthcare rock stars. For our first discussion, we'll be joined by Julian Harris, Chairman and CEO of ConcertoCare and operating partner at Deerfield, and Mona Siddiqui, Senior Vice President, Clinical Operations for Humana Home Solutions. In our second session, this is the case study panel with startup entrepreneurs, Ricky Sahu, the founder and CEO of GenHealth.ai and former founder and CEO of OneUp Health, Rachel Munsie, co-founder and CEO of Ounce of Care, and Sylvia Hastanan, CEO and co-founder of Greater Good Health. And then lastly, we'll welcome to the stage Kavita Patel, venture partner at NEA, and Sean Cavanaugh, Chief Policy Officer of Aledade. So with that, we'll dive into it. I'll invite my partner, Dan, to the stage for our first conversation with Julie and Mona. Thanks.
So much, Vic. We'll get both Mona and Julian on camera here. Thank you both for joining. We're thrilled to have you. I know you guys have both had some cross-country travel in the last couple of days, so glad you've been able to join us here. Both of our panelists today are clinicians, have spent a collective couple of decades in the government, and have worked at major national payers and have worked with early stage companies, so have a 360-degree view of how policy can impact startups in digital health. Mona, I'll start with you. Prior to your role currently at Humana Central, you are the Chief Data Officer at HHS. Talk a little bit about your collective experience in the government and how you've actually seen some early stage companies best leverage new regulations and or access to data to drive new market opportunities.
Yeah, no, thank you. Obviously, when I was in that role, overseeing the data portfolio for the department, yeah, we engaged early on in conversations around a lot of other initiatives that were at play, including all of the kidney care work that happened. And I think a lot of people don't realize that work actually started by career staffers in the Obama administration and then continued on to the Trump administration. And really that the team who was engaged in that work did a phenomenal job of convincing everybody along the way about the importance of that work. And I think it was also an example of where the team engaged industry people really proactively, right? They got feedback and there was a problem that was identified that we had to solve. But I think there were a lot of unknowns about how to go about doing it. And we can get more into that. But I think it was a great example of multi-stakeholder engagement very early on.
Yeah, no, I mean, you talk a lot about being proactive, engaging with people in industry, right? So kind of government officials can do that, but then separately, early stage company executives and operators and entrepreneurs can reach out to the government. Given that bi-directional flow of information, what have companies gotten right and what have they gotten wrong in engaging in that process?
I often hear, and by the way, this isn't even just for early stage companies. This even goes for the larger companies, where oftentimes I think folks are very reactive and they wait until they see the first draft of something before they begin to engage. Policymaking is a long process, as everyone in this call will say, and some of the best policies take many years to really formulate. And it's a missed opportunity to not engage early. So the companies that I think I've seen positioned really well to be able to leverage the policies are people who have been engaged in policymaking for 2 to 3 years at least. And so they are positioned then to be able to say, this is exactly the opportunity that we can go and leverage. And it's not a surprise at the end of that process.
Yeah, no, great insight. So it's get involved before you see the first draft of some form of policy and then maintain that relationship for 2 to 3 years. And to your point, it can be a challenge sometimes for early stage companies which don't have a lot of resources. Oftentimes, as you described, it's these large companies that are probably lobbying the kind of the federal government and perhaps creating suggestions for policy.
Yeah.
So,
and Dan, I might also share, oftentimes there may be white papers that are written by folks from a small company or a large lobbying entity. And those become some of the initial starting points for ideas that people begin to think about. And again, like I said, I think government is great at identifying the problem to solve. I think getting from here's the problem and here's where we're at, there are a number of things that we can account for from that perspective. And so having those ideas come to you and then being able to iterate on those, I think is incredibly important. And I think it's a missed opportunity when folks don't take that and don't share their ideas. And you can have a big budget and do that, and you can have a smaller budget and still do that. But I think it's about how much do you actually want to engage in that process.
now that's a great insight. And for all of our entrepreneur viewers, someone is reading those white papers. So keep writing those white papers. So that's good. Mona, I'm going to come back to you in a second to talk about your current role. But Julian, I want to loop you in to the conversation. Julian, you oversaw $1 trillion, yes, trillion dollars of spend in the federal government in your role as the chief healthcare financial officer with the Office of OMB, with oversight responsibilities for CMS and most other federal health organizations. Talk a little bit about where you see the catalysts for regulation and healthcare policy. Where is it coming from? Is it campaign promises? Is it primary market data? Is it key constituencies? And can entrepreneurs tap into these ecosystems to better position themselves?
Thanks, Dan, and thanks for having me. I think that there really are opportunities across the spectrum. As Mona described, policymaking really is, in many cases, an extended process, and it's an evidence-based process. And so in certain cases, there are policy priorities that may rise to the level of being a priority for at the state level for a governor or at a national level for a president. But in many cases, a lot of the policy that's ultimately implemented is really developed in conversation with stakeholders, with provider groups, with patient groups, with payers, with members of the legislature at a state level, with members of Congress. A number of stakeholders are helping to identify potential policy priorities. I agree that it is absolutely helpful for people at CMS or people who are in state regulatory agencies to have access to data, not just white papers with qualitative perspectives, but actual sort of research, creating an evidence base for policymaking or identifying problem areas. I'd also just underscore the people who spend their careers, dedicate their careers to working within a state health agency or working at CMS are people who are incredibly passionate about ensuring that beneficiaries, let's just take the case of CMS, the beneficiaries of the Medicare program and participants in the Medicaid program and the exchanges receive high quality care And they also have a commitment to stewardship of the public purse or public dollars, and thinking about opportunities to not only describe a problem from the perspective of a business or an organization, large or small, but actually trying to ground it in the impact on patients and beneficiaries. And in certain cases, even thinking about whether or not there are patient or beneficiary groups who might be partners in some of the research or partners in some of the advocacy. I think about areas like kidney care, or more recently areas that have gained a lot of focus related to maternal health, and really having the voices of people who've been impacted by some of the failures in our healthcare system in both of those two areas, I think has really helped to build a drumbeat of interest in thinking about how we both develop and scale programs targeting those two disease states or sets of conditions. I also think that there are opportunities to think specifically about reimbursement and how we take a long view. I'll take the example of hospital at home. We, as a country, have had conversations around, and I'd say at a pilot level in this country, at least, pilot level work around hospital at home for quite some time. In other countries, obviously much more common and deployed at scale. But in the context of the COVID pandemic and the public health emergency, November of 2020, we now have authorization for a pilot authority effectively for Medicare to reimburse hospital at home services. And we went from having roughly 24 or so hospitals in the country who were delivering hospital at home services to having, last count I saw, 289 hospitals that had received certifications to participate in the hospital at home program. And now the important work is really trying to build the evidence base for the impact of that program at scale. And thinking about the stakeholder work that went into making that happen, there were organizations, and one of them is one of our portfolio companies on the Deerfield side called Contessa, that had been in conversation with CMS around hospital at home long before the COVID-19 pandemic. But when that happened, I think they were probably well positioned to be a thought partner, along with a number of other organizations, certainly in that space, Medically Home and others, to be a thought partner for CMS as they sought to develop regulations. And then there were hospitals that were some of those 24 that I mentioned, who were the vanguard, who also, I think, had an opportunity to be thought partners for their federal partners in thinking about what a program might look like and being sensitive to some of the concerns. So one of the things I think people maybe don't have full context for is that the stewardship of the public purse that I mentioned. I think there's often a lot of concern about fraud, waste, and abuse. And before I ran the Medicaid program in Massachusetts, it's something I had some context for, but not full exposure to. Just both in the Medicaid program across the country and in the Medicare program, there really are significant challenges that have to be contemplated as you think about creating a new reimbursement structure. And ensuring that those challenges don't create barriers to innovation, I think, is really important. And it's another area where building an evidence base is really important, because in certain cases, the level of concern about those issues undermines the ability to drive innovation at a pace and scale that I think really would benefit the system.
Yeah, no, great insights, Julian. There are three kind of big themes that I took away. The first, Mona kind of touched on too, that oftentimes these policies are not necessarily made by the elected officials or high-level appointments. There are these kind of career government officials, these career staffers, right, who take this job extremely seriously, want to do the best thing for patient advocacy groups and patient families, and are really looking for the best solutions out there and really want to create impact. And so if early stage companies can find these individuals, navigate to these folks and help them in what is their kind of career stated mission, I think can be super important. The second piece that I pulled out.
A little bit of it on that. I think it's less about finding those individuals. So I don't want my former colleagues at the state and federal level have people looking on LinkedIn and trying to meet them for coffee at Starbucks. I think there are processes in place that states and the federal government have for getting feedback from stakeholders. And so I think we're probably both nudging that people should participate in those processes. It seems something that very big companies would do, write a white paper or attend a forum or a stakeholder gathering. But there really is an opportunity for smaller companies, for entrepreneurs, for people who haven't even started the company. They have the idea to participate in those processes that are established for getting feedback from stakeholders.
No, absolutely. The second piece is varying levels of data needs and quote unquote reporting to the burden of proof in order to impact, create a new set of reimbursement goals. You talked a little bit of the hospital and home program. There was clearly enough data required to create, call it a demonstration program, but that was just the beginning, right? In order for this program to become law and to graduate, so to speak, from a demonstration program, there's still a need for data to show real impact. And so there are varying levels of stages of burden of proof required. And so there's still work there. And then the last piece, I want to jump in.
Sorry on that second one, but I think it's also just something Julian said, right? Which is these companies and others in the space were accumulating that evidence, and actually up until the pandemic weren't able to make progress because they were hitting a brick wall. So you can't, it's not going to be a pandemic every time, but you can't anticipate some of the things that may change, that may help evolve people's perspectives around the importance of different programs. So the evidence met the opportunity and they were able to move forward. I think it could have been another triggering event, but if the evidence hadn't been there, they wouldn't have been able to move forward even with the pandemic. So I think that's an important piece. You can't always project how somebody's priorities may change.
Yeah, no, it's a great point. And then the last piece, Julian, that you mentioned, which again, I think is implicit in all these conversations about reimbursement. What is the CMS and the federal government most afraid of when creating new reimbursement codes? It's fraud, waste, and abuse. And so what can early stage companies do to allay some of the concerns that regulators have around fraud, waste, and abuse? How can, to your point, they provide that data, provide that evidence to show that there is real impact, while at the same time showing that there are some safeguards around fraudulent use of new reimbursement codes?
Yeah, I think it's probably an opportunity not just for early stage companies, but for companies and researchers and for-profits and not-for-profits broadly in the healthcare ecosystem. At times, we see the Medicare fee-for-service program actually leverage data from other sectors, so from commercial insurers or from Medicaid programs that have driven a particular innovation, or in certain cases, Medicare Advantage programs may have flexibility to innovate in a particular kind of way, and then the Medicare fee-for-service program can then learn from those insights. I think in the first instance, it's really, if you have an opportunity to pilot something or to try something with one of those other categories of payer, to do that and to obviously try and demonstrate that you can improve the quality of care and maintain or reduce the cost of care. I also think that it seems like a small thing, really ensuring that your organization has a culture of compliance and that you really focus on integrity as an organization, I think is important. So having as many bright spots and examples of people doing the wrong thing. And then there are companies that are focused, actually their innovation is that they're focused on rooting out fraud, waste, and abuse. There are data and analytics companies that are using artificial intelligence, for example, to look for ominous patterns in claims data. And that's another potential path for innovators, if that's your area of focus, to really support the agenda that CMS and states have to ensure that state and federal dollars are managed in a compliant way.
Yeah, great set of insights. Maybe in the last couple of minutes, both Mona and Julian, you guys are now focused primarily thinking about the home. And so I'm curious, what is your perspective on some of the regulations that are affecting, oftentimes around reimbursement, around home care and care in the home? Mona, maybe start with you.
Yeah, I think a lot of the conversations and debates are happening around more of the traditional fee-for-service model and entities that are continuing to essentially make the margin that they have been making. I think the conversation is beginning to change as a greater share of the patients that they're seeing are coming in with Medicare Advantage and not with original Medicare. And I think the conversation has to evolve to really looking at how do we provide more value-based care in the home? How are we paying for outcomes rather than for volume? How are we ensuring that the right set of clinical activities are happening and that it's not a compliance-driven approach? So I do think that the conversation just so often happens around that traditional model, and it really needs to be shifting into how we're oriented towards paying for outcomes.
Julian, I might give you the last word. You've now made the jump into entrepreneurship with ConcertoCare. Reflecting on your past kind of experiences and in your current role, what advice would you give entrepreneurs that may be facing either policy headwinds or tailwinds?
Thanks, Dan. At ConcertoCare, we leverage interdisciplinary teams powered by technology and data and analytics to support patients who have very complex health conditions in their homes, both seniors and adults who have complex health conditions across the medical, behavioral, and unmet social needs spectrum. I think one of the things that we have seen is that there is quite a bit of innovation from Medicare Advantage and D-SNP plans in the way they think about partnering with organizations like ours. And then there also are increasingly paths through the CMS Innovation Center demonstration programs to partner and think about supporting complex populations. One of the things I think that will be important over time, more broadly within the context of care in the home, is to think about, as Mona alluded to, both how you engage with an organization like ours that is thinking about care comprehensively, that's taking accountability for cost and quality across the broad spectrum of patients' care needs, but also how do you think about some of the people who are delivering care in home health or in hospice or in personal care. And certainly there's been an increasing focus on how the reimbursement landscape should shift for those provider categories. But much of that work and thinking, I think, has been more fee-for-service oriented. And I think over time, thinking about how you leverage some of those other provider categories as a part of a value-based ecosystem will be really important, both in the Medicare fee-for-service program as well as in Medicare Advantage and Medicaid.
Thank you so much, Julian, Mona. Such a great conversation. We could take the whole hour, but unfortunately we have to transition to our next panel. Thank you guys again, and really looking forward to all the impact that you guys will create in the years to come. Vic, I might hand it over to you for a conversation with a great group of entrepreneurs in the front lines. Thanks, Mona and Julian. Vic?
Awesome. Thanks so much, Dan. That was great food for thought advice for our next panel. So I'll maybe give it a second as we're joined by Rachel, Ricky, and Sylvia. All right. In this next section, we'll focus a little bit more on specific examples of early stage companies that are building on top of around policy headwinds and tailwinds. And we have some specific questions for each of the panelists here and some questions for the group. But maybe what I'll do is we'll start off with individual questions, and that'll give us an opportunity also to introduce the audience to your companies and what you're building. So maybe, Rachel, I'll start with you. So you were at the founding stages now of two companies. So Tomorrow Health being an innovator in the DME space, and now Ounce of Care, which is working at the intersection of health and housing, engaging Medicaid members in affordable housing developments. You recently spoke with Karen Dale at AmeriHealth Caritas of DC about your work in Medicaid redetermination, which obviously has become a big important topic as the public health emergency has expired. Can you tell us a little bit about Ounce and what you're seeing on the ground with the residents in your communities?
Yeah, absolutely. And thanks for having us all today. So for context, as you mentioned, very topical in terms of Medicaid redetermination. As of now, about 6 million people have already been disenrolled from Medicaid in the process of unwinding that policy during the pandemic of continuous coverage. But importantly, about 73% of those disenrollments are procedural. So this means the person might still be eligible for Medicaid, but it came down to process problems, missed deadlines, issues with forms and paperwork. And so what we've seen at Ounce, I remember talking to one of our community health workers, Isaiah, when the process of unwinding was kicking off, and he is out in the community hand-holding residents through this re-enrollment process. And so he sees these challenges firsthand. And he told us that it's really common for residents to not realize they needed to re-enroll and come to us after their Medicaid has already been terminated, which unfortunately means that person is all the way back at the starting line for the process, which can take months. So what we've started to see on the ground in our communities at Ounce is very concerning in terms of folks losing healthcare coverage for reasons other than actual eligibility. And we've been thinking of ways to obviously troubleshoot through some of these roadblocks and find solutions forward.
And so DC is one example, right, in the first geography that you're focused on. Do you have any good examples of what a local government can do to work hand in hand with entrepreneurs that are building out these solutions to try to alleviate this issue?
Yeah, so I would say first to think about some of the main roadblocks that we've seen, and then I think some of the ways that local governments and health plans, like the health plans we've partnered with in DC, can tackle those. Is the first is really that lack of awareness among Medicaid members that they need to re-enroll. So not magically assuming that millions of people will know about this important step, because it just hasn't been required since before the pandemic. And I think that stemmed from a couple of issues. The first, when we've spoken with states and MCOs, they just don't have the staffing levels and bandwidth to take on the sheer volume of outreach and engagement that really needs to happen. And there's so many steps to maintain coverage or re-enroll in coverage that the teams we've spoken with are fairly overwhelmed. And I think the second is, even when you attempt more targeted outreach or engagement to boost that awareness about the need to re-enroll. There is a challenge in terms of the effectiveness of that outreach. A lot of teams we've spoken with say the contact information is out of date, or obviously people might just discard mail notices that they think are junk. I know I've done that before for certain important notifications. And so even when everything goes right, that outreach can be ineffective. And I think the second is really just in terms of roadblocks in the re-enrollment process itself. So that experience and what does that look like? It's not super straightforward and it varies by state. The user interface for people to re-enroll can be clunky, it can be confusing. And we know that in speaking with local governments who are implementing on this policy of unwinding, they're balancing a need to iterate quickly in product and technology development cycles for the portals that they run for re-enrollment with these strict rules and regulations that govern most of their state and benefit portals. But an example of that would be things like forms not being available in Spanish or multiple language, which our community health workers have flagged as well, meaning that residents, family members, children who might be working as translators to essentially translate these forms so that they can re-enroll in Medicaid, which just shouldn't happen. Obviously, Ounce is really engaged with a lot of these key stakeholders to make these improvements. I think when we think about what some of these local governments and health plans can do better, and those who have performed well relative to others in terms of the policy implementation, I would say one is definitely a strong collaboration between the local governments and MCOs, and then pulling in those other stakeholders who can better engage Medicaid enrollees directly, whether that's providers, FQHCs, CBOs, organizations like Ounce. Since both the state governments and MCOs don't always have the channels and tools to do this type of engagement effectively or at scale, they need essentially to form these innovative partnerships. Obviously, AmeriHealth DC's partnership with us here at Ounce is an example of one of those partnerships in practice, but there are others that have worked well too. I would say the other is best practices around employing better data sharing. So local governments and DC actually just revamped their portal in particular, but other states have been doing this well. I think Maryland has done a good job of that, to pull in data from other benefit programs like SNAP or things that are based on income eligibility to essentially passively re-enroll people into Medicaid and other programs where you're tracking that income eligibility and that same type of criteria. It sounds easier said than done. I know the data can be siloed, it takes work and focus, but that's something that we've seen really well. And I think those two things could be really transformative for the work we do.
Yeah, it sounds like we all have our work cut out for us in solving that problem. And it's actually a pretty good transition to Ricky talking about data sharing and interoperability. Maybe I'll switch over to you, Ricky, for a second. And you also have now founded two companies, at least that we'll talk about today. And we'll get to GenHealth.ai in a second. But I remember when I first met you, I think that this was shortly after the 21st Century Cares Act had really come into being. You were one of the first entrepreneurs that I was aware of that was leveraging patient data access rights and FHIR standards to pull medical records out of hospital systems, health plans, which like previously was mostly paper, phone, and fax, if they were able to extract that information and share it at all. And so curious, if you could share with the audience a little bit about what it was like to build at that frontier and that requirement that hospitals and other healthcare entities provide data to patients for the first time. Ricky, you're on mute.
Thanks. Yeah, I started OneUp about 6.5 years ago now. And I think to Mona's point in the earlier panel, she mentioned how a lot of the companies that are able to capitalize and build businesses off of these regulatory shifts are thinking about the regs even before they are actually instantiated and passed and all that. And that's what happened with OneUp, where even before I started OneUp, I was involved working with Anish Chopra on healthcare data interoperability of this coalition of the willing for many people to get together and standardize on a common format for this, which was the FHIR FHIR format. And that was part of the impetus for starting OneUp, because I knew these regulations are going to come down And there are going to be many organizations that want to interact with this data without having to build connections to all the parties that are providing this data access. And that was similar to a Twilio or a Stripe-like situation, but for healthcare. But often what happens in healthcare is that these regulations snowball a bit and they end up becoming something more. And what ended up happening was, yes, there are these patient access rules that were required for providers to make their data available via FHIR APIs, but the federal government also introduced new regulations from the CMS side to support health plans and their members to make their data available via these FHIR APIs. And about a year and a half before those rules, the final rule was proposed, there is a proposal for a rule. And that's when we raised our hands and we said, okay, we're gonna support whatever this rule becomes. We didn't know that it would become all health plans making their data available via FHIR. And we started building towards that. And when the rule actually came out, we were actually really well positioned to support all health plans making their data available via FHIR APIs. And many other organizations put their hands up that day when it was a little bit later than would be beneficial to actually build this product. And actually some of those ended up leaving the market because it was just too late and too much to work on. So I think what we found is being early and having some conviction and an opinion about how to do it, even if it's not fully clear, is really a helpful approach in building around policy in healthcare.
It's really interesting. So you knew the shape of the rule and you built the company to suit, but didn't exactly know precisely where it was going to land. And that obviously worked out for you. And just curious, so part of what you're doing is dependent on hospitals, health plans, everybody, and you were enabling a lot of these parties to provide and comply with these new regs. But was everybody compliant and ready on day one, or did that take a little bit of time for people to understand how to react to this?
Yeah, not everyone is compliant and ready today. Yeah, definitely wasn't the case early on. I think from the provider side, there may be a dozen organizations that launched earlier than the deadline. And then when the deadline came, maybe only 20 or 30%, probably around 30% had been active and live. So it took some time for the industry to catch up. And the same thing happened, if not worse, for the health plan side, because all the health plans hadn't been using a vendor that was really structured to support these use cases. The EHRs were a natural fit, but the claims processing systems weren't the best fit for this sort of solution, it appears. And on day one, of the regulations being live, about 20 health plans were live out of the 300 and change that had to be regulated. And only 4 of those were organizations that OneUp didn't service. So we felt pretty happy about that. But leading up to that point was a whole lot of work. It was 4 months of what I call our implementation hell. And
Yeah.
it was not fun, but I'm glad we got through it.
Fascinating. And just to make sure that we keep on time schedule here, I want to switch over, Sylvia, to you in Greater Good. Greater Good Health is working with nurse practitioners and other clinicians to deliver primary care in new, novel ways. The Bureau of Labor Statistics, I actually recently learned this, estimates that nurse practitioners are going to be the fastest growing profession in the entire country, not just in healthcare, but the entire country for the next 8 years or so. And 28 states, I believe, are full practice authority states for nurse practitioners. And so you're operating in a world where the rules change state by state. So can you tell us a little bit about what it's like to scale a business when the rules kind of change depending on where in the country you're operating, and a little bit more about the Greater Good model?
Sure, yeah. Thanks for having me. At Greater Good Health, we partner with risk-bearing entities. So that's like health plans or providers. We enable their shift to risk. We private label and support them in succeeding in these value contracts. We bring care into the home alongside PCPs in their practices and also sometimes telehealth. And then later this year, we're actually launching our first cohort of primary care clinics where we'll be pioneering our NP-PCP model in a full practice authority state and doing that in a value-based care agreement with a major MA health plan. And we're focusing in on what we're calling tier 2 markets, where PCP physician supply is a dire problem and senior patients are waiting six months plus for a primary care visit. I suppose what's relevant for today is that we're really centering on empowering nurse practitioners. As the industry continues to combat the primary care physician shortage, we're trying to build an infrastructure, training, community, and readying nurse practitioners for value-based care. And I really believe that the nursing background of NPs are well suited for the outcomes-focused new care payment models that we're seeking to achieve. And there's tons, like you're saying, Vic, there's tons of scope of practice changes for nurse practitioners to allow them to practice at full extent of their education and clinical training, especially in primary care. 88% of those NPs actually are in primary care and come out practicing in primary care and family practice. And I think it'll be critical in meeting the nation's healthcare needs and combating the rising healthcare costs, but also the shortage that we're seeing that is becoming more relevant every day. And so we think about doubling down on leveling up the workforce, but also staying laser focused on the advancement of value-based care. And the scope of practice changes in 27 states. I guess it depends if you count DC. And yeah, I mean,
DC
there's
here.
like
This is a regulatory forum.
There's time for these changes to be implemented, right? So there's the interpretation of the law, there's administrative processes that have to be changed, and then there's adoption in the market. And then outside of the laws changing, there are a ton of operational adjustments we have to consider, and I'm sure others on this call have to consider as well, credentialing and licensing and how that's impacted. Also things like, and by the way, if anyone's listening, could use some transformation. If any policymakers on the line are taking note, credentialing and licensing, that is. And then things like attribution and billing are also really complex processes that are impacted by changes where a nurse practitioner is now the PCP of record versus the physician. So we stay on top of things like that.
And similarly, a lot of value-based care companies have to deal with risk adjustment, coding practices. The No Upcode Act is top of mind for a lot of folks. And a lot of people, we seem to think it's more of a when than an if. Can you talk a little bit about how that impacts businesses like Greater Good or value-based care in general? And then might quickly transition over, Ricky, to you again, and then move us over to the next and final panel here.
Yeah, as I think about managing care globally for Medicare patients, I describe it as a balancing act, securing the right and appropriate reimbursement for the care that you've already invested in and probably have already provided. And then on the other side of it, balancing how you're going to build cost containment, med management, chronic care management, quality programming to control costs and improve care for your patients. Related to risk adjustment, perhaps historically, there's been more of an emphasis on the reimbursement side. And what we're seeing, I think, at a macro level is that policymakers want to balance the scales there. And then how that impacts us is we're seeing our customers, payers, and providers, they want quality partners who are expert and comprehensive and less of the one and done. Let's just check off all these annual wellness visits, make sure patients are diagnosed, coded, and documented. But really, they're seeking partners who can help them think about the and then what, building the care plans, making referrals, following up, educating patients. And that works harder, let's be clear. But that's what we're answering for at Greater Good Health.
Awesome. And I think we have maybe 1 minute, but want to make sure we don't leave before we talk about generative AI. Ricky, so your new company, ChatGPT, new technologies at the forefront, and this is important for our next conversation, are operating at frontiers where we don't really have regulatory frameworks for yet. And maybe some people are a little bit nervous about the capabilities of these technologies. Can you tell us a little bit about your solution, and just want to do time cup? We have to make sure that we leave a little bit of space for the next panel.
Yeah, about 1.5 years ago, GPT was out. It was before ChatGPT, and GPT stands for Generative Pre-trained Transformer. And that's a transformer-based neural network trained on text data, which is why people are calling them large language models. And they're sequences of text data. So what we did was we took sequences of medical event data like claims or clinical sequences of patient histories, and we trained a transformer model on that. And what we found was that was just as revolutionary as what you had with language models and their precursors of NLP. You were getting the same sort of broad applicability via what we call large medical models built on transformers. And they can support all kinds of use cases, like what provider referral patterns are going to be, or what's network leakage going to be like, or what care is the patient going to get next, or what's their next likely diagnosis or cost of care, a whole bunch of stuff that is not really easy for LLMs.
So obviously it's the start of a much longer conversation that unfortunately we have to transition away from, but needless to say, fascinating business and a really important space. So we'll encourage folks to reach out to Ricky and learn more after this. But with that, we'll transition back, Dan, to you for our final panel here.
Thanks so much, Vic. Excited to invite Sean Cavanaugh and Kavita Patel to the stage for a last kind of conversation, bringing us home. Sean, thanks so much. I might start with you. Sean, talk a little bit about your experience at CMS. You have a very long and impressive background, spent decades in healthcare finance, spent time as a staffer on the Hill, some time at CMS, and now you're currently at Aledade. But talk a little bit about your time at CMMI, CMS, and we'll dive into how early stage companies can interact with CMS.
Sure, thanks. And hello to you, and hi, Kavita. It's good to see you. As you said, before coming to Aledade, I was at CMS for 6 years, and I had somewhat of an unusual experience in that I started as a career civil servant. So you heard the first panel talk about the career staff. And in that capacity, I was the deputy director of the Innovation Center. So those of you who are familiar with Liz Fowler, think of her career deputy. That was my role. I did that for 3 years. And then I transitioned and I actually became a political appointee, so transitioning in that regard, but moving to the Center for Medicare, where I was the center director. So going from, another way to think of it is going from CMS's research and development, R&D arm, testing new payment service delivery models, to the production arm, to Medicare, where we were responsible for all the payment rules in parts A, B, C, and D. So essentially everything you think of as Medicare. And so I had a fantastic experience, got to see all sides of the Medicare program and many sides of the agency, which is quite large, and as you said, has over $1 trillion of responsibility.
That's great. And I love how you described it, CMMI being the R&D function, trying to come up with new innovative approaches, and then the kind of core kind of CMS side is the safekeeper, so to speak, of that budget. Talk about that interplay. Talk a little bit about the making of the sausage, and maybe relate that to how early stage companies can best position themselves to put them on the right side of history with respect to new forms of reimbursement and enactment of policy that allows them to fulfill their mission.
Sure. In this regard, I'd make 2 points. One, when you think of CMS, and particularly Medicare in this regard, much of how Medicare runs is really dictated by statute. So think of CMS as administering a program where Congress has been highly prescriptive into how to run it. That still leaves a lot of decision making. So even small decisions in Medicare have huge ramifications, but they're really implementing very congressionally dictated program. The exception, of course, being CMMI, where Congress has actually ceded to the agency the authority to try new and different things with certain guardrails, but really, and certain opportunities to scale them if they're successful. So you should think of it in that regard. You have much of the program is heavily dictated by Congress, but then there's this innovation arm. So that's how to view CMS. But as an early stage company, I think one of the most important decision you make is what company do you start? And that has a lot to do with why I'm at Aledade, which is your posture towards policymakers will always be dictated by what is your business model. And Aledade was, not by me, but by the founders, was very much structured to be aligned with government's goals. So the government said through the ACA, and then reiterated by the Obama administration, reiterated by the Trump administration, reiterated by the Biden administration, we want to move particularly Medicare fee-for-service beneficiaries into value-based arrangements. We want to do it faster. And so if your company is aligned with a stated purpose of government, that changes your policy posture. Now you're talking about, hey, we're aligned. How do we both achieve our common goal? You're not selling your goal to the government. You're saying, how do we mutually achieve our goals? And I think that first decision of what is your company really will dictate your policy posture. Because if you're built around if you're selling the government on your vision, which is, no, government, you should be doing something different. That's not impossible. People have been successful there, but it is harder, and it does change your posture towards government.
Really,
Dan,
really
can I offer?
Yeah,
can I
please.
answer that?
Please jump in, Kavita.
I
And
just
Kavita, talk a little bit about your background as well while you do that.
It's okay. It's a good way to say that Sean and I are old and we've been around because we've done all these things in careers. And so I also started on the Hill and worked on FDA, NIH, ARC, a lot of quality issues, and then moved in a role at the White House I actually started on the auto bailout because why not? That's what we had facing us when we started the Obama administration in 2009, but then eventually found my sweet spot in healthcare. And then at the Brookings Institution, spent a lot of time working closely with Sean's colleagues that were implementing or at least ideating through some of the new value-based models, especially in specialty care. So I've traveled the terrain and I'm an internist. So I've seen it soup to nuts, but I wanted to just add on for the sake of time, kind of Sean's comment, because now I sit at New Enterprise Associates. We do a lot of work with Flair and other venture capitalists and thinking about early stage entrepreneurs. This is one of the most common questions that they face, how and when to get involved. Sean's comments are spot on. What I would also do is encourage, because we have so many really interesting aspects of the delivery of care. That's why I think people like Sean, myself, Mona, Julian, others who are really, Dan, you, people who are really interested in policy get very excited, because I think what we do in policy is incredibly entrepreneurial, but then entrepreneurs who are like the last panel, who are starting companies and creating, it really feels like you're at a loss. That like, how am I going to just talk to Sean Cavanaugh when he's at CMMI, or Liz Fowler or Mona when she was running the kind of the CTO office at HHS? And that's not the place to start. It's not the best use of your time and resources. You really do need to come together, I think, with other entrepreneurs who are in the similar space. And if you take chronic kidney disease, Dan, if you think, oh, there's only one company that can dominate this space, we all know that's wrong. And so you're in the rising tides lift all boats is a really good way to think about interacting, particularly around innovation models in the delivery system. And then to even think about that with payers, because I know that contracts are done kind of company by company, depending on your stage. But if you're really thinking about a change that's significant for Medicare Advantage, paying for supplemental benefits, and I know we're going to talk about digital health, which in a lot of ways is uncharted territory, it does make sense to come together. You do not need to come together and fund high-priced lobbyists, because most of what people in the government are looking for is like really direct feedback from developers, from entrepreneurs, from clinicians, from patients. I think that we don't talk enough about like what beneficiaries are telling us. And one of the newer models around dementia and kind of care for dementia patients is a good example of that at CMS. So I would just encourage people, especially any entrepreneurs or investors of any size who are thinking about this, to think about yourself in a peer group and thinking about coming together and engaging policymakers in that manner, because you can find that the impact can be far greater.
Great set of insights. A couple of ones that I pulled out. Sean, you had talked about as an entrepreneur, and I think this gets to the heart of this topic, right? Stroke of the pen, it can be risk or it can be reward. What is your business model? And how does it align with the government's kind of preset priorities? And if I were to maybe read between the lines and maybe insert a few ideas, make sure that you're directionally aligned with the government. And there may be pivots along the way. I love how you described Aledade's business model. It wasn't necessarily about ACOs per se. It was moving from fee-for-service to value-based care. And that may take a few forms and iterations, and clearly it did with the Trump administration around direct contracting. But if you're aligned, ultimately you can make those subtle iterations, but still be aligned with the government's purpose. And to your point, I love this concept of having a business model around the implementation of government policy, right? Because I think we all can appreciate that the government may not necessarily be the best entity to implement new practices and procedures on the front lines. The second one, Kavita, that you'd mentioned, and again, I think this is oftentimes anathema to how early stage startups think about their position in the market. There's so much about proprietary information, edging out competition. But your comment was like, build a coalition. Don't go it alone. And don't be afraid of competition, right? If you can have the government create a whole new market, that will benefit many companies in the market space. be a part of that and then use other tactics, so to speak, to outcompete the competition, but be a part of a broader coalition. So really great insights. And Kavita, I might jump to this next topic that you introduced, the future. Here on the last panel, we had Ricky, who is starting a business focused on generative AI. AI has been a topic of conversation, certainly at the FDA, but then now more broadly across the government. What kind of skill sets, what kind of statutes do you think give us a peer into the future? How will the government think about generative AI and the companies trying to build businesses on top of that technology?
Yeah, I'll be brief and curious also kind of Sean's perspective. I think we're all awaiting, it was supposed to come out in July, and the White House executive order that's broad around artificial intelligence, and it's supposedly coming soon, like in the next several weeks. I don't expect that to be some kind of prescription. I think it'll have these buckets that say we need to concentrate here, and then here's probably where we just need to listen and talk to folks. I do think it's interesting that the FDA, the VA don't diminish. We spent a lot of time, very importantly, talking about CMS and CMMI. But I would say that like what the VA is doing, they're going to stand up the first ever like kind of chief digital officer, and their kind of office is really tasked with thinking about the role of AI, not just in the like the direct delivery service for vets, but to also think about the business processes. And I think that's a very important aspect. I do feel like then the big overhang when Julian talked about hospital at home is thinking about a reimbursement mechanism around AI. I know there's already questions that have come up for the use of scribing AI, which is totally fine. However, I think that people are all questioning if an AI like kind of tool is used to respond to messages. And we now know that for inbox messages that there's actually codes and that we can charge for that. Many systems are doing this. Many providers are doing this because it's compensating for their time. Where does the role of things that are not requiring, so to speak, the human direct input solely, or the majority, would that come into the reimbursement framework? These are all open questions. I think they're good questions. And I think this is an example where you don't want government to think about these things in isolation, that we really do need to bring the kind of the three entities together: policymakers who are entrepreneurial but need to have the communication, kind of innovators and entrepreneurs, and then probably the most important is the people who are going to be using this and benefiting from it, the patients and clinicians. But I do think the White House EO and some of the things coming out of organizations like the FDA and the VA are ones to really closely watch.
I might give you the last word and maybe broaden the topic, just new frameworks around like completely greenfield technologies. How does CMS think about these?
Yeah, particularly with AI, I think what you're going to find is the current statutes around particularly Medicare, which is my area of expertise, and the regulatory framework at CMS it has never anticipated something like this. They're going to be inadequate, but this is an opportunity. And I think the Hill's going to struggle with it. CMS is going to struggle with it. But those of you entrepreneurs who know these technologies and know their capabilities, this is your opportunity to be a resource to government and to share with them what you know. But importantly, to have influence. It's not enough to be the smartest technologist. You're going to have to tie the ability of these technologies back to first principles. What is CMS trying to accomplish? CMS is not trying to accomplish anything around AI. They're trying to get people with better care at lower cost, more equitable care. So talk about the capabilities of these technologies to achieve those goals, and always tie it back to CMS's goals and how technology furthers that.
That's a great way to end our conversation, Sean. This can't be just about the technology, right? It has to be about the stated mission of the CMS to improve outcomes, reduce costs, and improve patient satisfaction and quality. So what a great way to end this conversation. Thank you, Sean and Kavita. Vic, I might turn it over to you to end our conversation. Thank you both.
Sure. And as always, I think we packed as much as possible into an hour and just made it to the finish line here. So wanted to thank again all of our panelists for joining and the audience members for listening in. Please encourage you all to continue the conversation with us and panelists. So with that, we'll thank everybody and have a great rest of your day.